Hello, everyone. Welcome to today's session with Professor Donald Chi. My name is Jim Crall. I'll be moderating the session today. We do have a few housekeeping items to remind you before we get started with the presentation. First is that you'll see at the bottom of your screen a Q&A box, and we'd like to ask you to use that Q&A box to record any questions that you might have, and I'll monitor those along the way and relay those to Donald. You also have the ability to like particular questions, and if you'll do that, it will indicate to us which questions are most popular or most pressing, and we'll try to move those to the top of the list for questions. We will allow time at the end of the presentation to go through as many questions as we can. And then if there are questions that we can't get to during today's session, you're free to use the Whova app to send questions to Dr. Chi, and he will make every effort to respond to those questions. So I'd like to introduce our speaker today, Dr. Donald Chi, who's a professor at both the School of Dentistry and Public Health at University of Washington. Donald is a board-certified pediatric dentist, also with a doctoral training in public health. His research has really focused on inequalities in oral health for children in many different areas, and he's going to be speaking today about a very important topic to all of us. Donald has received awards from the International Association for Dental Research as a distinguished scientist, and awards from the American Academy of Pediatric Dentistry for his work in pediatric dentistry. And so without any further ado, I'm going to turn it over to Dr. Donald Chi to address the topic of parents' refusal of fluoride. Donald, it's yours.
Great, thank you so much, Jim, and thank you for all of those attending this morning. I know bandwidth is in short supply these days, and we really appreciate you being here this morning. So today I'm going to talk about a topic that is near and dear to my heart, and this really has to do with parent refusal or hesitancy when it comes to topical fluorides that we provide in clinical settings. And just to give you a little bit of background, I know that some of the attendees, most of you are practicing pediatric dentists. I know that some of you may be in training, so some of you may be dental students or maybe residents right now studying to become pediatric dentists. And this topic, this research topic, it's 2020 now, this is a research topic. The genesis of this topic actually started probably about 15 years ago when I was a resident at the University of Iowa. And it's one of those things, I think it's a really good case study on if you kind of pay attention to what's going on in clinic, you really can come up with, I think, really cutting edge and important questions that we have very few answers for. So I want to put out the disclaimer that a lot of this research now is in progress. There's a lot that we don't know about parent refusal and hesitancy of topical fluorides, but I'm going to present what we do know, and based on that knowledge, provide some recommendations that have worked for me. But the disclaimer is that the work is in progress, and we hope over the next couple of years that we really will be able to expand our knowledge when it comes to parent refusal of fluorides. So I have no financial disclosures or conflicts of interest. Really, there are two objectives today. I want to provide you with an overview of the science of fluoride refusal behaviors in dentistry, with a quick overview of the predictors of refusal. So what are the factors that might predict a parent or a family that might have some hesitancy when it comes to topical fluoride. And I'm going to actually present some new data. These are hot off the press data. These haven't even actually been published yet. We're actually getting our publication ready right now. That actually will present a new conceptual model on the causes. And I'll explain later on why this is so important. And while we might think we have a good understanding of what drives fluoride refusal and hesitancy behaviors in practice, think this model really hits on some concepts that have forced me to really reassess where we are when it comes to clinical management strategies. And then what I'll do after I present the data that are available is to provide recommendations regarding clinical management or chairside strategies. So I'm going to back up a little bit. Again, the topic really is about topical fluoride refusal in clinical practice, but I think that much of what we see in clinical practice can be traced to community water fluoridation. So we know that here in the US, in the United States, water fluoridation is one of the 10 greatest public health achievements. We know based on data that water fluoridation leads to fewer caries. Water fluoridation, the effects of fluoride were discovered in the early 1900s in Colorado. And what McKay and colleagues found is that children living in particular parts of Colorado had a stain on their teeth. It was called a Colorado brown stain, and it was an enamel modeling where there were defects in the enamel. Now, while there were some aesthetic concerns about this enamel, what McKay and colleagues also found is that these children tended to have significantly lower caries rates. And really what the subsequent research found is that it was fluoride that helped to remineralize teeth and protect teeth from caries. And one of the really great things about community water fluoridation is that it eliminates disparities in access to fluoride. Everyone, in theory, has access to community water, and it removes inequities when it comes to access to fluorides. Now, you may know in your home countries or even here locally in Washington State, where I'm at, this is a very hotly debated topic. Many countries have decided to remove fluoride from the water supplies. But when it comes to really, how it is that we have gotten to the point where we can offer topical fluorides in practice, it really dates back to the research and discoveries related to fluoride in the water. Now, when it comes to topical fluorides, there are many different types of fluorides that are offered. And Falk's presentation earlier this morning talked about some of the modalities here. So we have a whole bunch of different ways we can get fluoride delivered to children in clinical practice. We have, varnishes, we have foams, we have gels, lots of different types of ways of getting fluoride delivered to children. We know that the evidence on fluoride varnish is actually pretty good. It's excellent evidence. It's very high quality, and we know that there's a substantial caries inhibiting effect that fluoride varnishes have, not just on primary teeth, but on permanent teeth. And this is a systematic review from 2013, a Cochrane review, looking at the effects of fluoride varnish in children and teens. Now, here in the US, we have a body called the US Preventive Services Task Force. And what the task force does each year is that they put out recommendations when it comes to preventive care. And this isn't just dental care, it comes in the form of all types of preventive care. And the task force puts together recommendations regarding prevention and kind of the highest quality evidence that's available for different preventive treatments and modalities of care. And so the U.S. Preventive Services Task Force is really conservative in their recommendations regarding preventive care. And so in 2013, the task force recommended 2 ways that primary care clinicians can help to prevent caries in young children. And the first is related to fluoride supplements for children who live in non-fluoridated areas, as well as fluoride varnish as soon as teeth start to appear. So when it comes to recommendations, again, the task force is very conservative, and yet back in 2013, based on the evidence, these were the 2 forms of preventive care related to fluoride that were released. However, there's a lot of resistance out there. So here in Washington State, we have a community over in the eastern part of the state, in a city called Spokane, where there's been a lot of recent community concern and uproar about efforts to put fluoride into the water. And so we have a local case here in Washington. But this happens in many communities when it comes to fluoridated water. Now, many of these concerns, may come from websites and different web-based sources that talk about the harms or the potential harms associated with fluoride. So these are just a couple of headlines. And if you go online and you enter water fluoride or fluoride, you'll see a lot of links to websites, articles that may actually raise concerns, many of which are scientifically weak. So here is a website on let's see, or here's a screenshot from curetoothDecay.com, and it's a blog posting talking about how topical fluorides aren't safe for children. And so a couple of quotes from this blog post. Fluoride is a poisonous substance. Common side effects include a whole barrage of different systemic effects, including brain damage and possibly even cancer. And it talks about a young child having died as a result of fluoride poisoning after visiting the dentist. So as a parent, and we have a new baby. She's 2 years old now. We go online for a lot of things. Things happen. She stops eating or she stops taking her nap, and we go to Google. We go online a lot to look up information. And as many of you know, the internet, there is a lot of information out there. Some of which is scientifically top quality. A lot of which is based on opinion, anecdote, and so it does take a discerning, critical reader and consumer to be able to sort through all these websites and all the available information online. From a parent standpoint, if I were to read this article and I wasn't a dentist and I maybe did not have good knowledge about fluoride, I'd be concerned. This is an article that would raise a lot of concerns in my mind. And this is the frame of mind that I think many parents are coming in with when they come and see us and they start asking questions about fluoride. A more recent study in JAMA talked about maternal fluoride exposure during pregnancy and IQ in the children. And this study actually raised a lot of concerns, got a lot of press globally. And obviously there were limitations with this study. And yet these are, again, the types of things I think that parents will come in with and ask us questions about. And so it's not just, I think, illegitimate blog postings based on anecdote or maybe even mis or disinformation being available online. I think there actually are legitimate sources of data, i.e. JAMA, where parents are going to be coming in with this information. And they're going to be leaning on us for answers to their questions. So in terms of 3 concerns about fluoride, and this is something that I talk to dental students and residents about when I teach public health and kind of the issues around fluoride hesitancy. What are kind of, in my mind, legitimate concerns versus those maybe that are maybe less legitimate? So I think 3 concerns about fluoride. One really has to do with autonomy. And I think this is related more to water fluoridation, but it also has to do with topical fluoride, is that the ultimate choice should be up to the individual. So opponents of water fluoridation will say that by putting fluoride in public water, you're taking away my choice to make a decision about whether I want the fluoride or not. So I think the debate at that point actually isn't about the fluoride, it's about the autonomy to make the decision. Same with topical fluoride. I think many parents come in and they know that it's their decision to either say yes or no to whatever type of treatment that we, in our best clinical judgment, offer and provide. And I think that autonomy is a legitimate concern. And I think it's something, we all learn about in dental school. We all learn about as health providers about the importance of preserving patient autonomy. Now, in the case of fluoride, I think that has to be balanced with health equity. I mentioned earlier that water fluoride, one of the really great things about water fluoride is that you don't have to depend on an individual to go somewhere to get the treatment. water fluoride is again theoretically available to everyone. And so I think that while autonomy is something that I think is really important to think about, health equity is the other side of that I think needs to be taken into consideration. The second concern is fluorosis. So here is a case of a patient that I saw in clinic that presented with severe fluorosis. Now, this type of fluorosis is not actually endemic here. So the type or the level of fluoride in the water present here in the U.S., there really are no water supplies that would lead to this. Now, this is not the case globally. So there are certain areas of the world where fluoride levels in the water just are really high. And so, patients will come in with this type of severe fluorosis. And I get it. This is a concern. This is a definite concern that I would have. This is not just a minor aesthetic issue. This is pretty severe fluorosis. What we see here in the U.S. is milder forms of fluorosis, and these are teeth obviously that have been dried and magnified quite a bit. And we can see here that this is more typical of the type of fluorosis that we see here in the US. But again, I think it's very legitimate. I think patients will have concerns. And again, this is something that we need to be ready to talk about. The third concern really has to do with water fluoridation and mortality. So here in the US, we actually have the one documented case of a death related to water fluoridation. And it happened in the early 1990s in a town called Hooper Bay in Alaska. And actually, this is the area of Alaska that I do some of my intervention work, and I've done some clinical work in this part of Alaska as well. And this is a single documented case where local water supplies got over fluoridated and there was a death. And so I think these types of cases, or this case in particular, may be something that parents come in with. And I think that, again, these unusual cases really do need to be kept in mind as we talk to parents about fluoride and the potential harms associated with fluoride. And so if a parent says, hey, I heard that there was a death related to water fluoride, and we as dentists say, oh, we don't know what you're talking about, like that's not true. Actually, it is true. And I think that, again, the history is something that we do need to keep in mind so that we have a context in which parents are coming in with information. In terms of fluoride refusal rates, I've done some studies here in the US looking at how prevalent fluoride refusal rates are. And again, this is going to differ depending on the community that you live in, depending on the state, depending on the country. Fluoride refusal may or may not be a big problem in your community. But we've done some work here looking at fluoride refusal rates. And what we found is that out of almost 600 US general dentists and pediatric dentists that were surveyed, 80% believe that fluoride refusal is a problem in their clinical practice. And 42% believe it's a growing problem. So I'm going to go back to my story about when I initially found this to be something that I found in clinic, and this was when I was a resident. And this is a case where back in 2006, I would have a few patients come in saying no to fluoride. And at first, it just was something that, piqued my interest and was just something that was interesting. But by the time I finished residency 3 years later, I had actually a collection of families who were concerned about fluoride. So even in those 3 years, I found that there was a growing number of families coming in and maybe not refusing fluoride, but certainly expressing concerns about fluoride. And when I moved back to Seattle, in 2009 to 2010, I found that in clinical practice there was a large number of parents who were fluoride. Now we asked dentists about what kind of characteristics in their mind come to mind when it comes to a typical parent or caregiver who refuses fluoride, and the characteristics that dentists reported are parents who refuse vaccines, white or Caucasian parents, and then parents from high-income families. And so this is based on more recent data. So in terms of the significance, we have an unresolved global caries epidemic. We have very few evidence-based preventive strategies, and fluoride is really one of the few evidence-based strategies that we have available to us. Now, again, some of you may say, this isn't a problem in my community. Maybe, Donald's making a big deal out of nothing. And I think that the argument that I would make is that we have seen this happened with other materials in dentistry, where I think consumer concerns have led to a situation where we don't have that material available anymore. And I think amalgam is a really good example, where from a public health standpoint, amalgam probably is the best restorative material that we have available, especially in terms of recurrent decay. And yet in a public health setting, many of us don't actually have access to amalgam anymore. And I think a lot of this was led by consumer concerns related to amalgam. But this has implications for other types of treatment that we currently provide patients. Silver diamine fluoride has both fluoride, but it also has silver in it. And we've heard anecdotally that parents will refuse silver diamine fluoride because of concerns not just about the fluoride, but also about the silver. And then other treatments that we provide, composites, sealants, radiographs. I mean, the list goes on and on. So I think this issue of fluoride is an interesting kind of case study in terms of what we do when there are concerns that parents have, and what kind of strategies can we develop to work with parents to make sure that they're making the best decisions for their children. This is a growing problem here in the US. And I think in terms of the role of inequities, I said before that dentists believe that this is a high income problem. And what we're finding here based on survey data that we've done here in the US is that income actually is not related to fluoride refusal. And what we're seeing is that fluoride refusal behaviors tend to aggregate at both ends of the income spectrum. You have the very high income parents as well as the very low income parents saying no to fluoride. And what that does, I think, is that it really puts the lower income families in a situation where they're at even greater risk for perpetuated inequities in terms of oral health. And in this currently we're in a current COVID-19 world, but I think that the discussions now here in the US and globally about refusals of a potential COVID-19 related vaccine, I think leads me to believe that fluoride refusal behaviors actually will get worse in a post-COVID-19 world. So these are things I think that we need to be prepared for. So in terms of studies on topical fluoride refusal, there really are very few studies before the studies that my team here at the University of Washington did. The couple of studies out there have looked at fluoride refusal behaviors in terms of why young children refuse. And not surprisingly, again, for those of us who work with young children, we know that younger children oftentimes will say no to many of the things that we do in clinic. So that can be provoked by anxiety, the fact that a young child has never had fluoride before, or no praise. This isn't actually the type of fluoride refusal that I find interesting. The second type, where a study here in the US by Rada and colleagues found that caregivers of children with autism were at increased risk for saying no to fluoride. And this is the type of fluoride refusal I'm interested in. This is the type of fluoride refusal related, again, to broader concerns about safety, about the role that fluoride has in terms of health. And so that really kind of was a springboard for our team to recognize that there were very few studies in this area. So what we did was back in the early 2010s, we did a prevalence study here in Seattle and in Washington to look at prevalence rates of fluoride refusal behaviors. And we had a nice variety of sites. We had the University of Washington Pediatric Dentistry Clinic, we had a community health center, as well as a private practice office. And this was both a chart-based and a survey-based study. And so what we wanted to do was look at the prevalence of fluoride refusal behaviors, as well as look at what factors were related to fluoride refusal with an emphasis on vaccine refusal. So what we found is that across the three sites, there really was wide prevalence rates of fluoride refusal, ranging from 2% in community health centers to almost 13% at the university. So if you average all of those rates out, we found that about 5% of families, this accounted for multiple children coming from the same family, about 5% of families were refusing fluoride. And again, so this is based on data from 2010. My guess is that these rates are much higher now. The second part of the study is, again, to look at this relationship between immunization or vaccine refusal and topical fluoride refusal. And not surprisingly, we found significant associations. So those families that self-reported refusal of vaccines were significantly more likely to also report refusal or hesitancy of topical fluorides. When we looked at other factors that could potentially be related to both immunization and fluoride refusal behavior, age was a confounder that we adjusted for in our final models, and the relationship still held between immunization and topical fluoride refusal. And the other two factors, or the other factor that we found to be associated with fluoride refusal is education. So parents who are college educated were significantly more likely to refuse compared to those who had completed less than high school. The next question that we asked was, are there common predictors? And so this is starting to get into the intervention realm. So, so the hypothesis we tested here in these analyses, and I know this slide is busy, you don't have to actually look at the odds ratios here, but we wanted to see, are there common factors that predict both vaccine and fluoride refusal? And the simple answer with this complex set of analysis that we did is that no, there were no common predictors for both vaccine and fluoride refusal. And really this was an attempt to theoretically look at the possibility of doing kind of a common risk factors based approach at addressing both vaccine and fluoride refusal behaviors. And these data, showed our team that probably wasn't a very promising avenue. The second avenue is that, okay, so we found that immunization refusal was related to topical fluoride refusal behaviors. So the intervention relevance of that question is that, okay, so in order to address topical fluoride refusal, do we tackle immunization refusal, and will that have downstream effects? Or do we have to take a separate approach? And I think this common risk factors question, the fact in my last slide that there were no common predictors for the two behaviors, really lends evidence that we need to take a separate approach, that fluoride refusal behaviors, while they may be associated with vaccine refusal behaviors, it's a separate behavior and it's going to require a separate approach. And this is what led us to the grant funding that I'm going to describe our initial set of findings from. And so, what we wanted to do was we wanted to back up a little bit and say, okay, we know that fluoride refusal is a problem in some communities. It appears to be a growing problem in the US and in other countries. We wanted to say, okay, so what are the factors that lead parents to be hesitant or concerned about fluoride? And we wanted to take a systematic approach because our eventual goal with all of this work is to develop chairside tools that help pediatric dentists identify parents who are likely to be hesitant or fluoride refusing, to diagnose the reason why they're hesitant. And I think that diagnosis is critically important in actually developing a solution or developing a communication strategy. Now, I think the problem is that, we see a fluoride refusing parent in clinic, and I think they're treated the same way. And as dentists, we have a couple of tools in our toolkit, and we unleash those tools without knowing the reason why a parent may be hesitant. And so I think that the reasons why parents come in with these concerns, I think is really critically important. So we conducted 56 interviews with fluoride refusing or hesitant parents here in Seattle. And we developed a conceptual model. And so this is the first conceptual model when it comes to fluoride refusal behaviors that there is. And surprisingly, while there's been commentary work in the vaccine world, addressing this question, there actually are no similar types of studies in the vaccine world. And I'd say that while I'm being maybe unfairly, overly critical of pediatric dentistry and pediatric dentists about the way that we address fluoride refusal behaviors in clinic, I think our medical colleagues do the same thing in medical settings. And I think the reason is the same, is that, again, we assume that parents come in and they refuse for the same reasons. And so we kind of use the tools that we have. We educate, we shame parents, we threaten them to leave the practice or to exit the practice. And so again, these are kind of the tools that we have, and so we use them. And I think a lot of that blame actually can be attributed to the research community. Again, I don't think we've asked the right questions, and this is an attempt to start to ask those questions that'll get us eventually to solutions that work. So, we could spend 2 hours going over the conceptual model that we've put together here. But really, this was a qualitative study, again, based on 56 interviews. And what we did was we came up with a core construct, which is a kind of a single sentence that describes all of the different domains that we found to be associated with fluoride refusal behaviors as reported by the parents in their own words. And then we have domains under that core construct. So our core construct here is that parents really described their reason for being hesitant or refusing fluoride is that they're trying to protect and not mess up their children. So they're trying to protect and not mess up their children. And I think that in this core construct, I think that if we can remember this, if anything else from this talk, I think it's you'll have maybe shifted your thinking, or at least solidified maybe some of the things that we know already about parents, is that parents love their kids. I don't think that any parent out there, or very few parents out there, are making decisions that they knowingly are harming their children. I think when it comes to fluoride, parents really are trying to protect their children. And I think the second piece about not messing up their children is rooted, I think, in deep-seated fears and anxieties that parents have about being judged. I certainly know this as a parent myself now, and I'm experiencing this as a parent, is that a lot of times you feel like you're under a microscope, and you're constantly being evaluated by society, by other caregivers, by providers, by us, about the decisions that we make. And I think this realization or this understanding that parents really are trying their best is a good starting point. Now, under this core construct, there were 5 separate domains. And so these are domains that again, based on what the parents were saying, these are the things that were related to their decision to be hesitant or to refuse fluoride. Now, these aren't mutually exclusive domains. A parent could subscribe to all 5 of them or just one of them. And then they can also subscribe to each of these domains, with varying intensity. So really strongly or really weakly. So the first domain is thinking topical fluoride isn't necessary. So a lot of parents talked about the fact that, we're post-fluoride. We don't need fluoride anymore. Maybe there was a time where topical fluoride was needed, but it's not needed anymore. And parents really cited a variety of reasons. The fact that caries can be controlled by good diet, low in added sugars, that cleanings and dental visits help to prevent cavities. And so, there was this thought that fluoride just wasn't necessary anymore. The second domain had to do with harm. So thinking that fluoride could be or is harmful for their children. And under this domain, parents talked about a whole slew of body systems, the kidneys, the brain, just any body system that you can think of, the nervous system, that fluoride had direct harmful effects for their children. And this was, I think, one of the most common themes, this concern about harm. Now, a separate thing that I think is related to the harm, but that actually is separate, again, based on our qualitative data, is a desire to keep chemicals out of their child's body. So this is separate from the issue that the chemical is harmful versus non-harmful, but it's a willingness or a desire to keep chemicals out of the body, especially those chemicals that are man-made or unnatural. And there are a lot of parents who actually talked about organic foods, that they are 100% organic, that they believe that fluoride is man-made, that it's a chemical, and that it's best to keep chemicals out when possible. I think the last 2 domains, and I'm going to go into a little more detail in these 2 domains with specific quotes, because these I think are related to maybe things that, that are more directly related to the way that providers talk about fluoride. The fourth here is talking about, parents talked about there being too much uncertainty about fluoride. You know, there's a lot of evidence out there. You know, some of these parents talked about, you know, hey, you know, fluoride may work, but there's also all this evidence out there showing either that fluoride doesn't work or that it's actually harmful. And so when you balance all the different evidence out there, and this I think relates to some of the information that's available out in social media, on the internet, that when you balance all the different sources of information and the information that parents get from their friends and colleagues and family members, that when you balance it all out, there's just too much uncertainty. And it's easier to make the conservative decision to say no. And then the fifth domain here has to do with feeling pressured to get topical fluoride. So this doesn't just come from dentists. So many parents actually talked about the pressure that they feel, not necessarily in words, although they certainly did talk about the way dentists as well as their staff members would talk about getting fluoride and why their child needed fluoride. But the general pressure from society, from governments, from insurance companies, just from everyone. And this is where I think this fifth domain started to kind of creep into the world of conspiracy theories, that you know, that basically all these parties are in it to advance their own agendas, and that child health and safety is less of a priority compared to these other concerns. So again, I think the conspiracy theory element was certainly present in some of the discussions that we had with parents, but I'd say it was a minority. It was a very, very small piece, but it was part of this fifth domain. So I'm going to talk about a couple of quotes here. So from the last two domains here, parents talking about uncertainty. So parents talked about a lot of doctors actually recommending that they not get fluoride for their child or children. You know, much of this actually came from not just dentists, but actually people outside of dentistry. So this could come from a pediatrician or a family medicine doctor. And I've certainly seen this quite a bit in clinical practice, where a parent will come in and say, well, you know, I talked to my pediatrician, and my pediatrician said, you know, cavities aren't a problem anymore. We don't need fluoride anymore. We're post-fluoride. The second quote here is, I found just as much information that was against fluoride as I found stuff that was for it. And so I was like, well, who's to believe? And this has to, again, do with just the fact that there's so much information out there, and it requires some time and ability to cull through data sometimes to determine what's legitimate information versus less legitimate information. And then this final quote here under uncertainty is, it's hard because you hear things that you give your children, that 1 decade or 2 decades later, they're like, oh, sorry, we messed up on this whole generation. So this idea that, you know, when it comes to medical or preventive interventions, that there are cases where, you know, we didn't know a lot about it. And so this possibility of potential harm that could be uncovered later, again, contributes to this uncertainty and pushes some parents into making a more conservative decision to refuse. When it comes to feeling pressured to get topical fluoride, one parent here talked about why is it that dentists are changing their verbiage to vitamins when it was called fluoride not too long ago. So why are we calling topical fluoride vitamins? It must be that more people are not wanting to do topical fluoride. And this certainly is something that I think hit home for me when we talk about health literacy and the way that we describe some of the treatments that we do in dentistry. I think that this first quote really has to do with maybe a basic misunderstanding of maybe some of the words that we use in dentistry that are misunderstood as being potential pressure tactics to get parents to make a certain decision. Another parent said, you know, the dentists are touting about how great topical fluoride it is, how great topical fluoride is, but it's just something extra for them to charge for. So it's something that we can make money with. So again, this concern that dentists are behaving in a certain way because of profit motivation. And then this last quote is, "He, the dentist, refused to give my child even a tooth cleaning unless I agreed to topical fluoride." And so this is an example of a punitive consequence of a parent deciding to make a particular decision that a dentist may decide to withhold treatment or maybe even dismiss a parent. And we certainly see this as part of some of the strategies that our medical colleagues use when it comes to vaccine hesitancy, is that you have practices that will dismiss patients as a result of this. So what do we do here? We have all this new knowledge about fluoride refusal behaviors and what causes it. What do we do? So this is where again, we can lean on the immunization literature a little bit, but not so much. And so the immunization literature has found that provider education, so this is an example, here we are attempting to educate and share and disseminate information about fluoride refusal behaviors, that provider education is insufficient in boosting rates of vaccines. Now, this isn't to say that provider education isn't important. I think we all need to be on the same page when it comes to knowledge around why it is that parents come in concerned about fluoride. I think what this study highlights is that it's not enough, that we have to do more than just educate providers. We need to actually provide dentists and staffs with effective tools that can actually help. Now, the same group here out of the UW looked at different communication styles. And what they looked at is participatory versus presumptive communication styles. And what this means in a nutshell is that participatory communication styles are where the pediatrician would go into an operatory with the parent and the child and actually approach vaccine decision making as a joint decision. And so we're going to make this decision together. What do you think? What would you like to do? Whereas presumptive communication styles actually presumes that the parent is going to vaccinate and starting there. So when it comes to these two different communication styles, the UW group found some preliminary evidence that presumptive communication styles were effective. And these are what I think parents would label as pushy behaviors, as in, this isn't a shared decision. A decision has already been made. It's a matter of how is that decision going to be executed. And what the same group found is that they did an RCT, a randomized clinical trial, and they found that these two communication styles, there was no difference in vaccine hesitancy afterwards. And so what this tells me is, again, that parents can pick up on pushy communication styles. And I think in the long term, what this can lead to is not just improvements. So we're not going to see any improvements in fluoride refusal behaviors. But I think what you can have is you have a phenomenon potentially called reactance happening, where parents who feel pushed into making a decision by a provider will go home, do more research online, talk to their friends, talk about this on social media, and come in even more resistant the next visit. And so here we are, we're well-meaning providers going in and intervening, and we have now at the next visit or the next, one of our associates, in our practice now has to manage a parent who's even more hesitant or more strongly hesitant about fluoride. So in terms of general strategies, again, I think that these are strategies that have worked for me, and I've published on this topic, so I invite you to take a look at this 2017 paper at the bottom here. There's some general strategies that have worked for me and that have helped me to manage fluoride refusal behaviors in practice. And by help to manage fluoride refusal behaviors in practice, this doesn't mean that these strategies work to get parents to accept fluoride. That's not the end goal necessarily for me. For me, it's to have a situation where parents feel good about the conversation, where I feel good about the conversation, where I feel like everyone's had a chance to say what it is they need to say. And at the end of the day, the parent is making an informed decision about fluoride. So this is not about trying to get parents to do something they don't want to do. I think that's just not the right way to view this. And so this 4-step, I think, set of strategies have worked to me to just make me feel better about these conversations, because I've certainly had interactions with fluoride refusing parents that have gone just badly, that have gone really poorly, and I've learned from those. experiences. So when you look at fluoride refusal behaviors, really, I think it's a spectrum from total acceptance on one end of the spectrum to total refusal. And I think that this red line here indicates kind of the varying degrees of fluoride hesitancy. You have some parents who might be mildly hesitant, who are fine with you putting fluoride on their child's teeth, all the way to the parent who's like, don't come near me with fluoride. I want nothing. I don't want the prophy paste. I don't want the fluoride varnish. I want you to check your water source. I don't want fluoride in that. So you have the total refusers as well. And so I think that there's a spectrum. And my experience has been, and this is consistent with our interview data, and we're going to be doing some large-scale surveys here in the next couple of months, is that the total refusers, I think, are actually pretty small. It's a minority, and that most parents are either mildly hesitant, kind of somewhere in this range here in terms of varying degrees of fluoride hesitancy. So I think that it's really important, first of all, to recognize that a parent has a concern. And this is the reason why the screener that we're developing is really super important. How many times have you been blindsided by a parent who talks about their concerns about fluoride, and you're actually in the middle of fluoride treatment? Like, not a good time to talk about fluoride hesitancy when you've already done an entire arch, when you've already applied fluoride varnish to an entire arch. I think discussing risk objectively is really important. So I think reinforcing the importance of fluoride if the child is at high risk. Just as important, I think, is to explain why it is that fluoride may not be needed at that particular visit if a child is at low risk. And I hope that everyone here is practicing based on risk, that not everyone who comes into a practice setting and is in the chair is getting topical fluoride. That's not the way fluoride was intended to be dispensed as a preventive therapy. So I think that when it comes to fluoride and risk, with those parents who we say, your child has never had a cavity, child's at low risk, diet looks great, everything looks wonderful. We're going to skip fluoride today if it's okay with you, but we need to explain why. And then how risk can change. And this certainly, we see this with teenagers who go through that stage where, at age 10, 11, 12, they're caries free, everything's perfect. And then once the teenager is able to make their own dietary decisions, for instance, the risk starts to increase. And so this is an example, I think, especially with those pre-adolescents, I'll talk to parents about how a decision to not apply fluoride could actually change at a subsequent visit. I think dispelling misinformation tactfully is really important. Dismissing parents, making it seem like they're not smart or that they're crazy. I don't think that really gets us much. And again, we don't have to use these words for parents to pick up on the fact that we're thinking them. So I think that's really important. And then maintaining communication. I think the other thing that I found is that, that these conversations about fluoride may have to happen over multiple visits, especially if this is the first time you've seen a parent. There's no trust that's been developed, there's no rapport. So it may be that conversations about fluoride need to happen over time. And if you start off your first visit and have a not so good set of interactions, it's hard to maintain that communication over time. So oftentimes I will not go into, trying to convince a parent about anything that first visit, or maybe not even that second visit, but asking permission to maintain communications at subsequent visits. And some parents will say, I will actually ask, is it okay? Would it be okay for you that we talk about fluoride again at the next visit? Some parents will say no, and I'm sure to include that in the chart. And so that's, again, an important piece about communication. So again, I think this 2017 article goes into a little more detail on these 4 general strategies when it comes to fluoride refusal behaviors, and hopefully you can take a look at that if you're interested in more detail. With that, I'd like to acknowledge my large team here. This wouldn't have been possible without them, and our funding sources. And with that, we'll use the remaining time for discussion and questions. Thank you very much.
Great, thank you, Donald. Appreciate the excellent presentation, your efforts to bring science to what is a very common clinical challenge that people are increasingly facing. And we'll move to some questions here. Before I do that, I'd like to say that we're very happy to be close to finalizing a process where Dr. Chi will become the editor-in-chief for the International Journal of Pediatric Dentistry, IJPD, and very happy that he has agreed to bring all this enthusiasm and knowledge back to us in a broader sense. So thank you. Let's see, I'm going to start first with the questions from the Q&A box. And the one with the most votes so far, Donald, you touched on this, but perhaps we can go into a little bit greater depth on strategy. Apart from parents, there are a growing number of dental professionals who are against the use of fluoride. How do we address the anti-fluoride advice provided by a growing number of dental colleagues, dentists and dental hygienists, who are also against the use of fluorides?
This is a really wonderful question. Yeah, I wish I had the answer to that. And certainly when you, so I have a Twitter account, you know, and I kind of keep an eye on what happens in the Twitter world. And you certainly see individuals with dental degrees, with dental backgrounds who are very opposed to fluorides in general, not just topical fluorides. And I think that's a really good question. Boy, I don't know. I really don't know, but it's fascinating. And honestly, I think that, you know, it's a variety of factors. I think that when you view this, you know, entirely, you know, kind of from a positive standpoint, you know, these public health, you know, clinicians and professionals may feel like they're contributing important, you know, knowledge to the debate when it comes to fluoride safety. And again, I think that's important. I think it's important to not just blindly say, well, everyone should just get fluoride. So I think that this is related to the issue of risk. And so if a patient is at low risk, do they need the fluoride? And in those cases, no, they don't. They don't need topical fluoride. So I think in those cases, you know, professionals really or you know, kind of maybe dental professionals who have concerns about fluoride are actually warranted. I think that in Europe, you know, there was a decision with dropping caries rates that water fluoridation wasn't as important. And that probably, you know, maybe was a good decision. I would be a little more concerned now, given the rates of sugar-sweetened beverage consumption now, that those rates are probably going back up again. So I think that, you know, it's one of those things that I think decisions about fluoride are gonna be fluid. It's not just, we don't need it, the case is closed, and we don't need to talk about it anymore. These are going to be dynamic discussions. I think the other thing is, you know, as a scientist, I'm always open to the possibility that there could be a study out there that shows something definitive about fluoride and harm. And I think that as public healthers and as clinicians, we need to be open to that. You know, the negative side to all of this is I think that there's also kind of a celebrity status with what comes with being against something for which there's a lot of good evidence. You know, we see this with Gwyneth Paltrow. She's an actress here in the US, and her Goop site, where she sells all sorts of just products that don't have any kind of evidence base. You know, ozone water, you know, alkaline or ozone-free water or alkaline water. Anyway, all these products out there, and there's a market for all of this. And so I think that's kind of the negative take on all of this. But it's interesting, and I don't know. I don't have a good answer. I think as dentists, you know, we should be well educated about these topics. But yeah, it's a puzzling phenomenon.
Great, thank you, Al. Second question from Dr. Gomez. Are there also studies and evidence supporting the concerns that parents have? And when you examine all of the literature, how do you factor that in there? You know, you mentioned we as doctors tend to approach this from a framework of conventional medicine, but there are other frameworks out there that relate to health and disease, and how do you incorporate that into, you know, some of that, you know, supporting the parent's interest, I guess, while at the same time trying to bring what we believe is the best evidence for a decision?
Yeah, absolutely. I think that's a really good question. And I think that, our conceptual model really helps to drive maybe some of the alternative strategies that might be available for us. So I think that this first domain about thinking topical fluoride isn't necessary, as well as the second and third domain. So thinking it's harmful and then wanting to keep chemicals out of my child's body. Especially with the first and second domain, the thing about fluoride being necessary or unnecessary, we can probably make a clinical judgment on whether we think something is necessary or not for a child. So I think that there's probably a more definitive answer there. Thinking that it's harmful, again, I think that we probably, based on the evidence, we have a definitive answer there. I think with this third point, and this maybe gets at the question that was raised about just philosophies about what parents come in with in terms of how they want to raise their children. And I think that this third factor, keeping chemicals out of my child's body, there's not really much you can argue about there. I mean, we know that fluoride is a natural substance. I mean, it's an element on the periodic table. I mean, while fluoride varnish is something that's man-made, the actual active ingredient in fluoride is in our water. It's in rocks. It's in soil. It's present everywhere. But if a parent is saying, I want to keep man-made substances out of my child's body, I mean, yeah, fluoride varnish would fall into that category. This isn't something we can pick off of a tree. So this is really where I think with the strategies, and this goes to the 2017 paper that I talk about, is talking to parents about alternative strategies. So I think that some of us could say, okay, you know what, you're not going to take fluoride, and I think you need it because your child needs to go to the hospital operating room. They have a lot of caries and treatment needs. I'm just not going to treat you, and I don't want you as part of my office. I mean, that certainly is a possibility. The alternative to that is, what are the alternative behaviors that can help to offset caries risk? And this is really where I think the dietary interventions come into play. And at this point, I think a parent needs to make a decision about what they want for their child, and I think that, we know that the caries balance, in a very simplistic model is a balance between remin and demin. And so you have the sugars that cause the demin, you have the fluoride that causes, or that helps to promote remineralization. So if we're going to take fluoride off the table, which that's totally, I think, in my mind, that's a parent's decision to make, and a child is at high risk for caries or is coming in with lots of lesions, that's a discussion we need to have about diet. Now, the other thing that, that parents will say is that, well, I give my kids organic foods. Well, organic has nothing to do with caries risk. And so that's an opportunity to have some discussions about education, about food. There still is a lot of misunderstanding out there about juices, about, juices being totally fine. And that's just not the case. And this is coming from even higher income, high STS. It happens all across the income spectrum. So I think, the short, that was a long answer. I think the short answer really is this opportunity, I think, to talk about alternative ways. And something's got to happen. I think a parent will say, well, diet is hard to change. And I know that. I mean, I've tried to cut out all sorts of things from my diet, and we know how difficult that is. It's not impossible, but at the end of the day, it depends on what the parent wants for their child in terms of health outcomes.
Yeah, great. And I'm glad you actually bridged over to a couple of questions we had in the chat box about, can you use the opportunity to sort of shift it to a discussion about dietary things. So that's great. We're getting pretty short on time. We will be able to extend a few minutes after the appointed hour, but then we'll have to bring this to a close, and people can use the Whova app to direct questions to Dr. Chi afterwards. A question, Donald, about, I know this is pretty nascent research, but have you, or are you aware of others that have looked at regional differences? So, one part of the country or one part of the world that might have, where this is a more prevalent sort of resistance to fluoride?
There haven't been any national studies in the U.S., not that I'm aware of, but we certainly anecdotally see this. As part of our current study, we have actually recruited offices from different parts of the country, and they do tend to cluster in particular parts of the country. And when we do informal polls, when we were looking for practices, we would talk to different dentists and pediatric dentists across the country. And some dentists say, you know what, this isn't a concern in my community. It's not a big concern. Whereas in other communities, it is a bigger concern. So yeah, so not any formal studies that I'm aware of, but anecdotally, I would certainly tend to agree that, yeah, that there are probably regional and local differences.
Yeah, great. Okay, here's another question. Do you have the same discussion with parents about fluoride supplements? And do you prescribe them routinely according to caries risk and water fluoride levels?
Yeah, that's a really good question. So when it comes to fluoride supplementation, I fortunately live in an area that is fluoridated, and most of my patients live in a fluoridated area, and they're using, they're drinking the public tap water. And so based on that, no, I don't actually use a whole lot of fluoride supplementation. When I first got out of residency, I did practice in an area that was fluoridated, but drew from areas that were not fluoridated. And in those cases, yeah, we would have that conversation about fluoride supplementation. And yeah, it's those same discussions, I think, about risk and need. And I think that, if a child, and I think that's the other thing, is that, just because a child lives in a non-fluoridated area, doesn't automatically put them at high risk necessarily. I mean, they could still come in with, with really nice teeth. The diet looks good. The parents using, fluoride toothpaste, or maybe they're not using fluoride toothpaste, but things look pretty good. And in those cases, no, I won't, do fluoride supplementation. I know that there is kind of sometimes an automatic assumption that if a patient comes in with lesions and with untreated decay, that there's no point in prescribing fluoride supplementation, even if they do kind of fall into that risk category of coming in, from a non-fluoridated area. And, and I try not to make my decisions for my patients. I know that, adherence to medications, and fluoride is a medication. In this case, prescription fluoride is a medication. I try not to make decisions for patients that come in, and I give them the option. But I tend to stress, and I think that when it comes to one or the other, so let's say the only choices I had, and this is a theoretical case, is fluoride supplementation, that the parent has to go to the drugstore once a month and get this prescription, even though it might be covered by insurance, versus toothpaste use twice a day. I would push the toothpaste use. It's so much easier to incorporate that into one's routine. Not that it's easy, but I think it's certainly easier than including a trip to the drugstore.
Yeah, great. Thank you, Donald. All right, maybe we can touch on maybe one more, and then there's a question. Do you want to at least acknowledge the impact and perhaps some of the counter information that's been developed through review by public health dentists here in the States about the JAMA paper, the associated fluoride with IQ and things of that nature? So I want to touch on that at all.
Yeah, and there were lots of limitations with the study. It was actually analytically, it was a well done study. So again, I'm not going to argue with the stats. The stats were fine. The statistics were fine, and that's something you'll see with a lot of papers out there, that the stats just aren't even good. So I think that the stats were fine. There were limitations. This was a retrospective study, meaning that that individuals weren't allocated fluoride at birth or during pregnancy to then see what happened to IQ subsequently. So this was retrospective. I think the other issue is that that there was a measurement issue, and I think that measurement is always a problem in terms of making sure that your fluoride measures are appropriate and accurate. And so I think that that's something to keep in mind. I think the other concern that we'll see, and this study was based on data from Mexico, the other concern that we see with a lot of the studies that show detrimental effects of fluoride, especially water fluoridation, is that the studies draw from sources of water where the fluoride levels are, they lead to the type of fluorosis I showed you at the beginning. This is crippling fluorosis, where these children likely have bone issues as well. So again, this is that's the kind of fluoridation we're talking about. At least here in the U.S., there are no known areas with fluoride in the water like that. And so And I would imagine that's most of the rest of the world is like that as well, even though these hyperfluoridated areas may exist. And so I think that there is a potential problem with taking a study from an area where fluoride levels were super sky high, and then saying, okay, well, therefore we should pull fluoride out of the water here in the US or in an area where the fluoride is much lower. So I think there's an external generalizability problem with these studies as well.
Yeah, great. All right, thank you. Well, we're going to have to wind up the sort of open part of the question, but again, encourage people to contact Dr. Shi if you have additional questions. To me, what I've taken home as a message here is that fluoride, many issues we need as pediatric dentists to make sure we're developing a robust set of communication skills and acknowledge different ways of communicating with different types of parents. So just as we're doing Carrie's risk assessment, we need to understand and what's motivating the parents' attitudes and do the best job we can on behalf of the child to help them make the right decision overall. So again, thank you very much, Donald, for an excellent presentation. We had lots of attendees, close to 200 as we went along. So fantastic presentation, and thanks everyone for attending.
Thank you.
And that concludes our session. Thanks.